guys, welcome to part 2 of our rapid sequence intubation. So we're finishing it off. Rapid sequence intubation. Okay. Rapid sequence intubation. So we said earlier that first thing, pre-oxygenation, and we did explain why it has to be done. You know, this thing of rapid sequence intubation, the sequence of events is very important, and they will ask you on the exams. They will ask you. I know in UP they even use a drop box to arrange the sequence as they should. Okay. So pre-oxygenation, once you're happy with that, you give a drug that will blunt intubation response. Drugs of choice: fentanyl, lidocaine, or the topical spray. The commonly used one. Like I said, I recently learned that even some people use rock. It's fine. And we said that intubation response is actually a stress response that causes stress response that occurs when you intubate a patient, and that causes an increased amount of a catecholamines in the blood, that increases blood pressure, that increases the pulse. And we said that you don't want that. That's why you are blunting that response. Even if it occurs, doesn't put the patient's life in danger. So that's the drug you're gonna give. Fentanyl is a drug of choice. It's an opioid. The nice thing about giving an opioid is that at the same time you are also taking care of intra-op pain, because it's an analgesia, as we know. And then the third drug, let's say the third step, is cricoid pressure. I'm gonna put it here. Cricoid pressure. We are gonna talk about cricoid pressure, right? So cricoid pressure. The issue of cricoid pressure, I don't know if I did explain it on part 1, I can't remember. But the issue of cricoid pressure, I'm going to explain it now, why it's done and how and what's the thinking behind it. But what you want essentially there is to make sure that if a patient happens to maybe vomit, they don't you are preventing aspiration. Basically, you don't want that gastric content to go up the esophagus and make its way to the trachea and into the lungs. So now the issue, when do you actually do the cricoid pressure? Different articles say different things. So you give the induction agent, which is propofol. The thing is, once you give a patient propofol, you are gonna make that patient unconscious, and once they become unconscious, their airway will be compromised. The patient that is unconscious, their airway is gonna give way. So, which means cricoid pressure is important to start doing it either just before you give the propofol. But the important thing is, when propofol has its effects in the body, by that time you want to have already done your cricoid pressure. You wanna be busy with your cricoid pressure by that time. You don't want to give propofol, the patient loses consciousness, and then later on you wanna apply cricoid pressure, because it might be too late. The thing is, what makes a patient to, like I said, what compromises a patient's airway here is not only propofol, and it's not only the muscle relaxant, which we're going to talk about. Those two drugs, they do, and I will tell you why. The first, like I said, with the induction agent, which is propofol, it makes the patient unconscious, and because the patient is unconscious, their airway is unprotected. You can lose an airway, so they can't protect their airway. A patient who's unconscious cannot protect their airway, and the induction agents, they render a patient unconscious. So that's why we want to apply that cricoid pressure just before the propofol, not after. I don't know if you can be quick enough to apply cricoid pressure as you give the propofol. I don't know. But what is important is that you want to have your cricoid pressure by the time the patient by the time propofol starts to have effects, meaning when the propofol starts to knock out the patient. So, and then there are people who say applying a cricoid pressure before propofol can be uncomfortable and can actually cause pain to the patient. So there are different things, but the important thing is, remember that you give propofol, you do cricoid pressure because you know that your propofol will make a patient unconscious, and they cannot protect their airway when they are unconscious. That's number one. Number two, the saxmethonium that you give after the propofol, which is step number 5, saxmethonium or scoline. It's a paralytic, It's a paralytic agent. Paralytic agent. So, what saxmethonium does is to relax. It's a muscle relaxant. It relaxes skeletal muscles, and in the case of airway concerns, the lower esophageal sphincter relaxation becomes crucial. So it relaxes the lower esophageal sphincter. Once you relax the lower esophageal sphincter, this is the stomach, you've got a sphincter there. Once that sphincter, the muscles, which are skeletal muscles, once they relax, this opening dilates, and the patient is also on a recumbent position. So now it's easy for the hydrochloric acid to make its way out and actually get into the esophagus and get into the trachea. So that's number one. So that's how saxmethonium is a danger when it comes to the airway. And then, like I said, propofol makes the patient to be unconscious. And if you are unconscious, you can't protect your airway. So you can lose your airway. You can lose your airway. Okay. So the step number 3, 4, 5 is very important. It's very, very important. That's why I said anesthesia is more about knowing the sequence of events. Imagine you have these drugs, but you don't know which one should go first, and then you give saxmethonium at number 3. What's going to happen? Or this is how it should be done. Okay. What I wanted to talk about is the let me try to remember it now. Okay, what I wanted to talk about is the why is it important to have an induction agent and saxmethonium. One of the reasons is that I've explained some, but the other reasons is that imagine, okay, let me rephrase this. The reason why you still need sax even though you have given an induction agent is that saxmethonium is the one that because it causes paralysis of the vocal cords. So causing paralysis of the vocal cords actually helps with intubation, so it facilitates intubation. Facilitates intubation. So it's very important. If you give propofol only and then you try and intubate, you might injure the vocal cords because at that time they have not relaxed. And also, yeah, you might injure them and you might even cause laryngospasm because if you irritate vocal cords, they can just go into spasm and then you've got a problem now. So that's why you need to give that saxmethonium. But why do you need propofol as well? The reason why you need propofol is that imagine if you can give a patient saxmethonium without giving them propofol or any induction agent for that matter. You're gonna have a patient who has been paralyzed, but they are fully conscious. They can see what you are doing. They are aware of what you are doing, and because they are fully conscious, that would be very cruel, and so you don't want that. You want to make them unconscious, give them the amnesia, and so that's why you give the 2 of them. I'm sure there are other reasons as well, but the ones that are in my mind right now are those. You can't afford to give propofol only, because if you give propofol only, like I said, your vocal cords have not been paralyzed, so you're gonna have a problem intubating because you have not facilitated your intubation condition. You have not made the conditions conducive for you to actually intubate the patient, right? And also, guys, one thing that you must also remember, muscle relaxants, they work on skeletal muscles. That's why if muscle relaxants were working also on smooth muscles, it means we're going to have problems with smooth muscles as well. You're going to have GIT spasm. You're going to have, everywhere there's a smooth muscle, you are going to have you are going to have relaxation of every smooth muscle. Bladders would just go, patient would just have, anywhere there's a smooth muscle, those smooth muscles would actually relax, and even your blood vessels would just dilate, and that will decrease your peripheral resistance, and you'd have a very big problem with hypotension. and that patient will actually die, because imagine having a smooth muscle relaxation throughout the body. It means your MAP is going to decrease, blood pressures are going to decrease, you're going to have hypoperfusion to all your organs, and it will be a disaster. So it's nice that muscle relaxants, they work on skeletal muscles. Okay, so now you've given your sacs, so you give it about 30 to 60 seconds to work, and then after that, number 6, you intubate the patient. After confirming placement, then you can secure. So step number 7, confirm placement. Placement, secure, and yeah. So guys, that's your rapid sequence intubation. Hopefully I'm not leaving anything out, and I hope I did justice to this topic. Guys, let's talk about cricoid pressure now. Cricoid pressure. Cricoid pressure. Okay. In the neck, we have got what they call a hyoid bone, hyoid bone, and below that we have got a cartilage, things like this. It's called a thyroid. Cartilage. And then below that you have got like this. So you've got this cricoid cartilage. So when they ask you to do a cricoid pressure, they want you to press on this using your 3 fingers. You use your 3 fingers, which is your thumb, your index, and your middle finger, like that. So you just push it, and then that's what is called cricoid pressure. Why do you do cricoid pressure? So as you go down, this trachea has got, remember you have, but I don't want to talk about that now. You have got it's not important for this. So you've got a membrane here, and actually if you have to do, the thing is, this landmark of the cricoid cartilage is very important, because in the event where you need to you do a tracheostomy and all of that, this is still the landmark that you use, because this is the area where you need to either poke in that cannula or whatever the case may be. If you are doing a surgical, this is where you actually make your mark, just above that cricoid cartilage. Anyway, so it's an important landmark, so you need to know where to find it. So if you can palpate your thyroid cartilage, as you go down, there's gonna be a membrane there. The next hard structure there is the cricoid cartilage. Below that you have got markers finished. So below that you have got C-shaped cartilages up until you get to the bronchus, the right and the left main bronchus, right? beautiful trachea. So did I just say beautiful trachea? Anyway, okay. So between here you've got cartilage. I mean, sorry, membrane. Even there's a membrane. Even there's a membrane. The difference, if you look at all of these are all C-shaped. These ones, they are like this. So at the back, there's no cartilage. Unlike the cricoid cartilage, the cricoid cartilage is complete like that. It's complete like that. And remember, below the trachea runs you find the esophagus like that. You find the esophagus like that. So if you are doing cricoid pressure, what you want to push this complete. It's a complete ring. These ones are C-shaped, right? This one is a complete circle or a complete ring. So if you push the cricoid cartilage, you push against it, because it's complete there at the back, you will sort of like create something like this. We are going to squash the esophagus like that. So you're gonna squash it like that, such that you even close it, because at the back there you have you've got, I'm not sure if it's 6C, not sure what C it is though, let me not lie. So there's a this is the cyst spine, one of the vertebra of the cyst spine, cervical spine. So pushing the cricoid cartilage, if you push it, because it's complete there, this posterior aspect will go and push against and squeeze the esophagus against that cyst spine vertebra, such that you end up having something like this now. Something like this. Something like that. From your pushing. So when you do that, remember, we said that you do this cricoid pressure for patients that are unfasted. So when a patient is unfasted, there's a lot of water there. I mean, hydrochloric acid, gastric juice, food, everything. So once a patient has been induced, they have a muscle relaxant. This will open, as we said. Once this open, whatever that is inside here is going to go up. Now, as it goes up, when it gets to this, it will be obstructed, so it won't cross, it won't go above that and enter into the trachea and cause aspiration, right? So this is the idea or the thinking around cricoid pressure. So it's done for, like I said, for unfasted patients, like I said. So as long as you understand this part, then you understand why you need to do the cricoid pressure. I hope that I've covered it, and yeah, thanks guys.